If you have to go in blind, this is the only safe way to access the giant vein.
Femoral line is the fastest and safest, followed by supraclavicular subclavian. The preference does depend on the experience of the physician as well.
And hold compressions.
Regarding how it's done, first we position the patient supine in Trendelenburg with 15 to 20 degrees head down. The head is turned slightly away from insertion side and arm is relaxed at side. We're aiming for the junction of the medial and middle third of the clavicle, but coming from above. First we find the clavicular head of the sternocleidomastoid muscle. Just lateral to it is the clavicle. We target the supraclavicular fossa, the small triangle bordered by lateral head of sternocleidomastoid, clavicle and clavicular belly of trapezius. Now we insert needle just above the clavicle at the lateral border of sternocleidomastoid. We aim the needle 10 degrees medially toward the suprasternal notch and 45 degrees posteriorly toward the opposite nipple. The goal here is to pass over the first rib and under the clavicle to enter the subclavian vein where it joins the internal jugular.
A centimeter from the lateral head of the sternocleidomastoid, a centimeter off the clavicle, aiming at the contralateral nipple. Amen.
We advance slowly while aspirating blood. The presence of dark, non-pulsatile venous blood, as shown here, confirms entry into the subclavian vein. Now, the process is the same as any other central line. Guide wire in, remove needle, dilator in and out, catheter over wire, remove wire, and finally flush and secure the central line.
Okay, resume compressions. And squeeze blood.
Where'd you learn that?
MRAP podcast. We'll be ready for a second unit in under a minute. Boom.
Okay, not too much blood on your dressing, Mr. Grayson. You're looking good. Mr. Grayson? Hey, Mr. Grayson!
For context, this was a case of scalp laceration which was stopped using Rainey's clips, the ones which are normally used for stopping bleeding from the incision on the scalp done before craniotomy.
Oh, must have dozed off. It's like a bad dream.
Yeah, no kidding. You, did you happen to see who shot you?
No. I heard the shots. They just kept coming. Gunshots and screaming. I'm never gonna get that out of my head.
GSW to the right inguinal region.
Yeah. Hi. I'm Dr. Whitaker.
Carmen?
It's nice to meet you.
You don't go on shaking hands of a patient who has been shot. If the right inguinal region has sustained a gunshot injury, the femoral triangle and its contents could be injured, like the femoral nerve, artery, and vein, along with external iliac artery and vein. Depending on how the bullet was angled, if it was angled upwards or sideways, it could have also injured the urinary bladder, especially if it was full, could have injured the urethra since female urethra is short, only 3 to 4 centimeters, could even be small bowel loops like terminal ileum if trajectory is high, along with other organs like ovaries, fallopian tube, or uterus, all depending upon the depth and path.
I'm just gonna take this. Hey. How's the pain?
Here, we control the hemorrhage immediately with direct pressure and hemostatic gauze or a junctional tourniquet, as inguinal wounds are too proximal for standard limb tourniquet.
I can handle it.
Okay. What is this, team bleak? What does that mean?
Like it's a coconut pudding from Puerto Rico. We top it up with canela. Cinnamon.
Oh, wow, so you got a food truck.
Just a folding table for
Fetal
now.
pulses are strong.
Dorsalis pedis has a strong pulse. It means the femoral artery is likely either intact or there hasn't been much compromise yet.
Let's start with antibiotics, pain meds, and let's try to stop this bleeding. Okay. Here we go. Okay, could you take over? Thank you. Hey. No. Inguinal GSW with active bleeding.
Try an Israeli bandage.
An Israeli bandage is a trauma dressing designed for rapid one-handed application to control moderate to severe bleeding in the field, especially in combat or pre-hospital trauma care. Here, a sterile dressing pad is placed directly over the wound. The elastic wrap allows firm compression. Then, we use a pressure applicator bar to loop around the wound and apply focused pressure directly on the wound. The closure clip secures the wrap without tape or pins. This combines both dressing and pressure bandage in one pack.
What if it bleeds through? It's at the top of the leg. There's no room for tourniquet above the wound.
An inguinal wound is in what we call a junctional zone, meaning it's too high for a regular limb tourniquet or an Israeli bandage, but still has major vessels that can bleed out rapidly. The standard tourniquet Won't work because it works by compressing vessels against the bone like femur or humerus. In the inguinal area, there's no cylindrical limb segment to wrap around, and the vessels are deeper and more surrounded by soft tissue. If we try to put a limb tourniquet that high, it either fails to occlude the vessels or causes severe soft tissue injury without stopping the bleed. That's why we use a junctional tourniquet here. A junctional tourniquet is designed specifically for junctional hemorrhage like in inguinal or axillary region. For inguinal region, the tourniquet uses a pressure pad or bladder that presses directly over the vessel origin at the groin, which is the common femoral artery against the pelvis. Technically, we could use an Israeli bandage for an inguinal wound, but it's not ideal as the sole control measure because the groin is a junctional area where the leg meets the torso, so we can't get a limb tourniquet high enough. The Israeli bandage's pressure bar can help, but it's hard to get enough force in the soft, curved anatomy of the groin compared to a flat limb surface.
Well, let's just hope the hemostatic bandage works.
Here we apply direct pressure immediately. If available, junctional tourniquet is used to compress the vessel where it enters the pelvis. If not, we could go for hemostatic gauze and direct manual pressure.
Hey, so, coconut? Love coconut.
Sarah? Yes, this is Lupe.
Whitney, you texted me.
Let's take a walk over here.
Can you tell us your husband's name?
Vincent Rivera?
We're gonna show you some photos. Can you tell us if this is Vincent?
He's not talking?
No, he's not.
I like that the show has these moments where we see doctors or other medical staff delivering bad news to the family members. It's a very delicate and sensitive process and often weighs on us if we are in a specialty where we have to do this on a regular basis.
Yes, that's Vincent. Can I see him?
Vincent had a gunshot to the head. When he arrived here, there was no pulse or breathing.
The patient was likely brought dead.
My husband is dead.
We're so sorry.
What about my brother, Brian? Vincent and Brian went to the festival together. Is my brother okay?
Can you send us his name and photo?
I did.
Okay, well, as of now, he's not one of our fatalities.
Do you have some relatives or friends we can call to come be with you?
Support systems like other family members or friends or relatives are necessary, so we often ask this.
Our kids are with my parents.
Second unit's in.
Holding compressions. Cardiac pulse. You feeling it?
He goes right after pre-op.
So, the blood transfusion from the supraclavicular subclavian central line worked to restore the blood volume. Now, the patient has to be operated to identify the bleeder and treat the intra-abdominal hemorrhage that led to shock in the first place.
Hey, not a person of interest, jewelry store owner, no priors. Yo, he's not our shooter.
You guys good in here?
We got this. Take a 2-hour lunch.
Let me go check on triage. We'll save a spot for you.
Go look at the wheelchair.
Hey, Ahmad, what number are we up to?
85 patients so far.
Need a gurney for Pink. How are you guys doing?
Still going strong.
Not bad, I guess.
You guys are triaging great, believe me. This is not easy. Not everybody can pull this off.
Is this your halftime locker room speech?
Yeah, possibly.
A great team leader, Dr. Robbie is. We gotta reassure our team members and make them feel appreciated of what they're doing. Otherwise, stress and anxiety creep in to become overwhelming at this distressing moment of seeing a lot of wounded patients at once.
Yeah, are we winning or losing the game?
Too soon to tell. Come on, these heads have to be up 30 degrees. Let's go.
Got 4 back here.
Through the head. No pulse. Black and white.
The patient is likely brought dead here, hence black and white to the morgue.
Pink zone. Strong pulse. Unresponsive, no obvious GSW.
Must be a case of blunt force trauma. I guess this could be due to stampede causing head injury or restricted chest wall movement.
Red zone, GSW, left chest.
She was talking when we first got in the truck.
We carotid unresponsive.
So, the patient has lost a lot of blood volume due to bleeding, and now this has resulted in severe shock which has rendered her unconscious. So, definitely red.
There was so much blood, I tried to stop it.
Jake?
Robbie, Leah got shot, it's really bad. I've been putting pressure on the wound the whole time.
Yeah, that's good, that's good. Are you
I
shocked?
don't know, maybe my leg, but most of this is her blood.
Somebody you know, boss?
Yeah. Come on, let's go, let's go. I got you. Come on. Great. Right here.
His stepson is okay with minor injuries, could have easily been much worse. But his friend is in a critical condition and clinging on the verge of life and death.
Jake, you can't stay with her.
I have to.
There's no room, and we need to work on Leah right now, and you need to get your leg checked, so please go sit down.
Please go tell me how she's doing, okay? Please?
I will. Jake?
I'm okay. Leah's with Robbie.
It's necessary to loosen or cut all the clothing to relieve any obstruction it could pose on the airway. Tight clothes could constrict the trachea in the neck, while also restrict the work of breathing in the chest. Hence, they're removed altogether. Airway in unresponsive patients in shock should be secured with intubation, as the work of breathing may be compromised.
Can't feel carotid.
Okay, start compressions. Swap out with me. I need an IO. Hang a unit of O-neg.
These people aren't pressing the bag in the bag mask ventilation here. It's absolutely necessary to press the bag to pressurize air into the lungs unless the work is done by a ventilator.
Got the IO.
Leah?
Yep.
You need help over there?
Nope, we're good.
It's Jake's girlfriend.
Oh, shit.
Who's Jake?
It's like Robbie's stepson.
Just let us know if anything is too uncomfortable.
It's okay.
This needs to be tighter.
They're doing pressure dressing here to stop the bleeding. As pointed out before, we could use a junctional tourniquet.
You bled through the last one pretty fast.
Try a 180-degree twist. It'll put more pressure.
Got it.
I usually faint when my blood gets drawn.
Must be all the adrenaline today.
Hippie's looking pretty out of it.
No, he's sleeping.
No response to pain.
Shit.
Here, there could have been intracranial bleeds masked here by the scalp laceration. The bleed caused increased intracranial pressure and reduced cerebral blood flow, and now has led to him being unconscious.
Yeah, Mr. Grayson? Mr. Grayson?
Could be a delayed head bleed.
He's gonna need a head CT.
He's not getting one anytime soon.
Equal and reactive, no blown pupil.
Blown pupil means a fixed dilated pupil. If pupils are equal and reactive to light with no blown pupil, it mainly rules out uncal herniation from raised intracranial pressure, where part of our brain, that is the uncus of the temporal lobe, squeezes through one of the openings, which is the tentorial notch. The classic early sign here is ipsilateral blown pupil from compression of the third cranial nerve. However, this finding does not guarantee the absence of significant brain injury. We can still have diffuse brain injury, concussion, hypoxic injury, or even elevated ICP early on before pupils change. Pupillary changes could be late in some traumatic brain injury cases.
Santos, go get an attending.
I'll try, but no promises.
Excuse me, I think I'm still bleeding.
I'll be with you in a minute.
So we're back ready. Here you go.
Pleur-evac refers to a commercial chest drainage system used after placing a chest tube. The 3-chamber drainage unit with collection chamber, water seal chamber, and suction control is primed and ready to receive the chest tube once inserted, so any air or blood from the pleural space can drain safely.
Princess, take over as primary.
What about Bridget?
She's stuck in yellow.
Mel needs an attending.
Find somebody who's free.
Dr. Abbott, can you come
Gonna
here?
be a minute.
Dr. Walsh? Taking one up to the OR.
Seems like the ER isn't going to catch up to the number of patients today.
Hey, I need a portable pulse ox for Mr. Grayson. Here you go. Hey, what happened to the kid in the wheelchair with the bloody right leg?
No idea.
Pinpoint pupils. Probable OD.
The patient's meiosis or constriction of pupils is being interpreted here as likely due to an overdose. In that case, the drugs implicated would be opioids like heroin, fentanyl, and morphine. Opioids stimulates the oculomotor pathway via the parasympathetic Edinger-Westphal nucleus, which causes constriction of pupils. Basically, the classic triad in opioid overdose is pinpoint pupils, respiratory depression with slow, shallow, or absent breathing, and decreased level of consciousness and responsiveness.
Blood on his clothes wasn't his.
I'll grab some Narcan.
Sublingual injection.
Naloxone, the opioid antagonist and antidote to opioid poisoning, can be given intravenously, intramuscularly, subcutaneously, or intranasally. Intranasal is common using a nasal atomizer. Sublingual naloxone wouldn't work in an acute overdose because absorption would be too slow. Also, the patient is usually unresponsive with poor airway reflexes, risking aspiration. Sublingual forms exist only when combined with buprenorphine in opioid use disorder treatment, not for emergencies.
Okay here?
Looks like an opiate overdose. How's Robbie's Leah?
If this guy doesn't wake up, we'll check for occult trauma.
I don't think sublingual injection exists. At least I've personally never seen it being done anywhere. Sublingual administration would be ineffective in emergency because naloxone needs to reach the bloodstream quickly to reverse life-threatening respiratory depression, and absorption under the tongue would be too slow and incomplete.
1,400 of blood out the chest, first unit's in.
Squeeze in a second unit fast and then we'll do another pulse check.
You need the second line?
For FFP and platelets.
You sure, Robbie?
The blood units here are called packed red blood cells. FFP means fresh frozen plasma, contains all the plasma proteins including coagulation factors that could help form blood clots and stop bleeding. Platelets would also help form clots since every blood clot starts from aggregation of platelets at first.
So if we get the plasma, I'm gonna take over compressions and swap.
The patient is intubated, blood has been replenished, and she has no pulse. No pulse and unresponsive usually would mean black and white. She has poor prognosis, and even if the bleeder is identified and fixed in the OR, it would be too late. He's gonna collapse if he stands right there bleeding from his leg.
Jamie, wheelchair? Man, you can't be in here.
They're working on my girlfriend. I need to see what's going on.
What's going on is you're losing a lot of blood. You're gonna pass out if we don't stop it.
No, I'm not moving, man. Leave me alone.
Jake, get in the damn wheelchair.
No.
Now, go!
Nah.
Real-life naloxone reversals can look as dramatic as this. In opioid overdose, mu-opioid receptors in the brainstem are blocked by the drug, causing respiratory depression and suppressing the respiratory drive. Naloxone is a competitive antagonist. It boots the opioid off those receptors and takes its place. And this effect can be almost instant with IV, which takes 30 to 60 seconds, and a bit slower with intranasal or IM with 2 to 3 minutes. If the patient still has plenty of opioids in their system, once naloxone hits, the brain suddenly realizes it's suffocating and there is massive adrenaline surge. The patient often wakes abruptly, sometimes shouting or thrashing in a confused, agitated state, gasping for air, complaining of pain because naloxone also removes opioid pain relief, and sometimes vomiting.
Welcome back, sir. You're in the ER PTMC. What's your name?
Martin?
What'd you take, Martin? You overdosed at Pitt Fest.
I took one Percocet so I could dance. I've got a bad knee.
Percocet is a combination of oxycodone, an opioid, and acetaminophen. Even just one pill can cause trouble if it's a high-strength dose, if the person has low opioid tolerance, if they mixed it with alcohol, benzodiazepines, or other depressants, or most probably if it was counterfeit, which is common on the street, as pill sol as Percocet may contain fentanyl. A healthy adult taking a prescribed Percocet for pain is unlikely to stop breathing, but fentanyl-laced street Percocet can cause rapid, severe respiratory depression, even from one pill.
Where'd you get the pill?
From a friend.
Hey, while you were overdosing from the fentanyl on a fake pill, there was a mass shooting at Pitt Fest.
What?
Ignorance was bliss here.
Hey, Samira, see if you can go help Mel in the yellow zone.
Take my new friend Martin with you.
Javadi, roll with me.
2 units, packed cells in. FFP still going?
Almost there. Okay, holding compressions.
We hold compressions during CPR to check for sinus rhythm and pulse, the two signs of return of spontaneous circulation. Here, we check for pulses.
Can't feel carotid.
No femoral.
Resuming compressions.
What's your next move, boss?
Platelets, another unit. And then we can transfuse her with her own blood from the pleurovac to get ahead. Hang the cell saver.
They're planning to do autotransfusion from the chest tube collection system. If a patient has a massive hemothorax and we're draining large amounts of blood from the chest, we can filter it and give it back to them, which is called autotransfusion. This can be crucial if you're short on donor blood, like in a mass casualty incident. This is usually done only if the blood is collected within minutes before it clots or becomes contaminated. It requires a closed, sterile autotransfusion setup.
Squeeze all this in?
No. Three-way stopcock and a 60cc syringe. I'll push-pull.
Okay.
Not exactly in our mass casualty game plan.
The risks of autotransfusion include air embolism, contamination, or infection. Most importantly, we shouldn't ideally be wasting resources and time on a patient with poor prognosis. The patient is unresponsive with no pulse. She would typically be, according to the protocol, tagged black and white and sent to the morgue so that other patients whose lives can actually be saved with immediate treatment can be provided time.
I tried, no attendings available.
Okay.
Right. Okay, those look pretty superficial.
Might have been fragments from a ricochet off the ground. Just lost a lot of blood, but you're gonna be okay, bro.
It's not bad. Just put me back in the wheelchair.
No, stay in bed with your leg up. We don't want you oozing to death.
Elevation reduces hydrostatic pressure in the injured area, and this helps slow bleeding and minimize swelling. Movement, especially standing or walking, raises blood pressure in the limb and can restart bleeding. Also, if there's a recent clot forming that's stopping the bleeding, movement could dislodge it and can restart bleeding too. So, rest and elevation of leg here are important.
Samira, what you got?
Opioid OD needs observation after Narcan.
Boring. No, thank you. Mel, how's gone to Grayson?
We can put him in pink while he waits for ICU.
Okay, 1 second.
What are you doing?
Checking the retina.
If a head injury patient suddenly loses consciousness, we would be thinking about expanding intracranial bleed causing raised intracranial pressure, which could compress cerebral blood vessels to cause loss of consciousness. Here, an ocular or retinal ultrasound is being used to look for signs of increased intracranial pressure after head trauma, particularly optic nerve sheath diameter measurement. We can also detect vitreous, hemorrhage, retinal detachment, or papilledema.
For detachment?
For intracranial pressure by measuring the optic nerve sheath, which is...
The optic nerve sheath expands when the intracranial pressure is high because it's continuous with the subarachnoid space. Measuring its diameter with ultrasound can be a quick bedside clue for raised ICP. Optic nerve sheath diameter, more than 5 millimeters in adults, is suggestive of elevated ICP, which would be highly suggestive of intracranial hemorrhage in a head injury patient.
Holy shit, 10 millimeters.
What's normal, 5? Yeah, 5. It's an intracranial bleed. The pressure's been building up. There's no blown pupil.
Yeah, not yet, but if he keeps bleeding in his skull, he's gonna die.
Yeah, and elevated intracranial pressure eventually leads to brain herniation, which means brain gets squeezed through the openings in the skull. There are different types of herniation based on which opening does the brain get squeezed into. If the uncus of the temporal lobe squeezes through the tentorial notch, this is called an uncal herniation. Elevated ICP can progress to uncal herniation, at which point the ipsilateral third cranial nerve will be compressed, leading to fixed dilated meaning blown pupil. Not only this, it will progress eventually to tonsillar herniation, where the cerebral tonsils get forced down through the foramen magnum. This compresses the brainstem, particularly medulla. We know that medulla lodges the cardiorespiratory centers responsible for heart rate, blood pressure, and the work of breathing. If it's compressed, the breathing can stop, leading to apnea, and the heart rhythm becomes unstable and eventually stops to an asystole, leading to death of the patient.
Yeah, he needs a 1-inch burr hole in his with a cranial.
A burr hole is essentially a small hole drilled into the skull to relieve intracranial pressure or allow access. It could be employed for emergency neurosurgical decompression if a patient is herniating from a suspected hematoma, especially epidural hematoma, to drain blood to reduce pressure.
I'm just going to see if neurosurgery is here.
We don't have time to wait for neuro. I got betadine and a 10cc syringe.
Should we intubate, hyperventilate?
Mannitol decreases ICP.
These are all the other methods of controlling increased ICP, before jumping into a burr hole craniotomy or decompressive craniectomy, where a part of the skull is removed to relieve intracranial pressure due to brain swelling. In ideal settings, we first secure airway with intubation to protect from aspiration and allow controlled oxygenation. Then, we can hyperventilate cautiously to temporarily lower partial pressure of carbon dioxide to cause cerebral vasoconstriction. This reduces cerebral blood volume and hence decreases ICP. The target partial pressure of CO2 would be 30 to 35 millimeters of mercury, but we should avoid prolonged hypocapnia, which could rather cause cerebral ischemia due to prolonged vasoconstriction. Also, we can go for mannitol, which is an osmotic diuretic that draws water from brain tissue into the bloodstream and eventually as urine, hence lowering ICP. We also elevate head to around 30 degrees to promote venous drainage, and we avoid hypotension at all costs to maintain cerebral perfusion pressure.
Holy shit!
Relieving intracranial pressure so he doesn't die.
So, this is absolutely not recommended, no matter how emergency the situation is. We gotta understand that IO drills are designed specifically to penetrate the long bones like humerus, tibia, or femur for intraosseous vascular access, not skull bone. Skull bone is thicker and curved, requiring precision to avoid plunging into brain tissue. Neurosurgical burr holes require specialized cranial drills with depth control and proper bits. Using an IO drill risks over-penetration, so there would be high chance of direct brain injury.
With an IO drill?
That's sick. I get the next one.
But all is not on me.
Dana, is neurosurgery down here?
Ask Princess.
Princess,
Rest, ICU.
I need a neurosurgeon.
They're all in the OR.
Dr. Walsh, I have an epidural in the north corridor with an elevated ICP.
Is there a blown pupil?
No, but a 10 millimeter optic sheath on the ultrasound. We need a burr hole.
Draining the ICH with an ECIO.
Another thing here is that there would be uneven drilling and the bone fragments would cause damage. You'd essentially end up doing more harm than good. The most common site of an epidural hematoma is the pterion. The pterion is just above the zygomatic arch, anterior to the ear, which is the typical site, as epidural hematomas usually arise from the middle meningeal artery here. I guess the scene is trying to show the blind IO drill over the site here, suspecting an enlarging epidural hematoma, which may not even exist, and there could be some other type of intracranial bleed too.
40 cc's out so far.
Like she said, what?
There was a case report in the 2022 Journal of Emergency Medicine. Patient survived, went home neurologically intact.
She's talking about this study. This was a case of a 17-year-old female patient who was intubated. Neurosurgical services were not available and transport to the nearest pediatric trauma center was delayed due to weather. So, the physician had no choice other than to decompress and drain her EDH with an easy IO driver and intraosseous needle under virtual guidance of a pediatric neurosurgeon until definitive care could be obtained. The patient made a full neurologic recovery. It's important to note here that this was a CT scan, confirmed epidural in a pediatric patient, under the virtual guidance of a pediatric neurosurgeon regarding the depth and risk of overpenetration, which is crucial.
Optic sheath is back to normal.
Starting purposeful movements. Ready to intubate.
Propofol, rock, and mannitol.
I'll let neurosurgery know. We'll get him off ASAP.
Incredible save.
If he lives.
Yeah, the chances of direct brain injury due to this are profound and could present later on.
Third unit's in.
Okay, holster.
I think I'm feeling ephemeral.
I got a carotid. Emery, I got a chest case. Needs to go to the OR.
There is return of spontaneous circulation with palpable pulses here. The girl needs definitive surgical management to stop the bleeder in the chest wound right now.
Saw you doing CPR. Let's go.
2 liters out of the left chest. Got a pulse back after 3 packed cells. 600 out of the cell saver, 2 of FFP.
I'm not feeling it.
Take a carotid.
Nothing, sorry.
The pulse has been lost again.
Resume compressions. No, we should take her up. She just had a pulse.
Not now. We need a pulse go to the OR.
A pulse indicates perfusion, meaning the patient's heart is pumping blood effectively enough to sustain vital organs, which is critical for surviving anesthesia and surgery. If there is no pulse, like in profound state of shock like this, either the patient doesn't have enough blood or the heart has stopped working. In either case, surgery under these conditions is impossible since the anesthetic and other medications won't circulate. It would also be pointless since the patient may have already died at that point.
Tell me if anything changes.
Do we have any more whole blood from the donors?
Think so.
Okay, get another unit. It's got platelets and plasma. It'll help her clot.
Got it.
4 units. Blood is for the ones we can save.
This goes against his own set protocols of triage he described earlier, but he does want to leave no stone unturned in this case.
She is right on the edge. One more can make the difference.
I'm in.
End title looks good.
So, they've intubated the epidural hematoma patient. He would definitely need proper neurosurgical exploration for his bleed.
Okay, OR team can take it from here.
We need to check on the others.
I should get back to Pink. Stay strong, Crash.
Hemostatic bandage still in place. How you doing, Carmen?
Not so great.
Okay, let's see.
It looks arterial.
Agreed.
Arterial bleeding is often bright red, while venous one is dark red or maroon. Arterial bleed usually spurts or pulses with the heartbeat, and blood may soak bandage in bursts or spray out. Arteries tend to bleed faster and more forcefully, so bandage may have fresh, bright red blood stains which are soaked quickly. Venous blood oozes or drips and doesn't spurt, and has slow bleeding rate.
Can you stop it?
Direct pressure for now.
Yeah.
We may have a junctional tourniquet in the disaster supplies.
Can you get that?
Junctional tourniquet for this inguinal bleeding case has finally been mentioned. As we said before, inguinal and axillary wounds are in junctional zones, meaning they're too high for a regular limb tourniquet or an Israeli bandage to wrap around them, but they have major vessels like femoral or axillary arteries that can bleed profusely. Standard limb tourniquets require limb circumference and a compressible area distal to the injury, which is not possible for very proximal wounds near the groin or pelvis. Applying a regular tourniquet too high can be ineffective or cause tissue damage. These cases merit the use of a junctional tourniquet. The tourniquet uses a pressure pad or inflatable bladder that presses directly over the vessel origin, here at the groin, which is the common femoral artery, against the pelvis. Common junctional tourniquet devices include SAM junctional tourniquet, combat ready clamp, or junctional emergency treatment tool.
Cool. Whitaker, in the meantime, just put pressure on it and try and stop the bleeding.
For how long?
As long as it takes.
Bled through his Curlix.
Elastic pressure dressing, yep.
Got it. Got a better bandage, and we're gonna elevate your leg.
Curlix is a loosely woven gauze roll, while elastic bandage is a stretchy, woven bandage with elastic fibers, which provide compression to reduce swelling and control bleeding.
Do you know what's happening with my girlfriend? Her name is Leah. She was shot in the chest.
I'm sorry, we have a ton of patients, and they're only marked by numbers.
When Robbie and Dana were working on her, they were doing CPR.
How do you know Robbie and Dana?
Robbie and my mom were together for a couple of years, and I would come and hang out here.
Well, I'm sure if they're helping her, then she's in great hands.
Can you check for me, please?
Sure, of course, just after I finish this.
Again, the fear of the unknown will engulf patients unless reassured.